So yes, I'm going to talk a little bit about the history of psychedelics in the Netherlands, and particularly also psychedelic research in our research group. It's not going to be a comprehensive overview. For that, I do not have too much time. But I would like to pin out, to show some of the highlights that are interesting to discuss. Let's see. I think in the Netherlands, the situation of psychedelic research is not different from the situation in the world. Basically, you can make a distinction of the situation before psychedelics got scheduled and after. And in the Netherlands, that actually occurred in 1966. And before that, psychedelics have been used in psychiatry. And there's basically 3 prominent psychiatrists that have been mentioned quite a lot. There's even a book written on them. And I think the most famous of them is 𝗝𝗿𝗥𝗺. And he, but also Kees van Rijn and 𝗣𝗿𝗥𝗺, they treated patients in psychiatry with primarily LSD, sometimes also psilocybin. But if you go back into their files, the files that are available, and there are not many, you can actually find out that they haven't any clear-cut criteria on who should actually be treated and how should they be treated with LSD and which dose. And I think you have to remember that in the Netherlands and also worldwide, in the 50s and the 60s, psychopharmacology as such was not a well-developed discipline. People were, in psychiatry, psychoanalysis was still the main discipline that was being followed. And that's also why, for example, psycholytic therapy, so the combination of psychoanalysis and the addition of LSD was like the common way of treating patients. So 𝗃𝗿𝗺 broke the ground in the Netherlands, primarily because he treated people who survived concentration camps in German camps in Poland. And it took a time before people started to realize that they actually built up traumas. But at that time, the whole term of post-traumatic stress disorder wasn't even known, wasn't even defined. But I think he put trauma as such, as a psychopathology on the map in the Netherlands. And there are also lessons to be learned from them, because even then there were events that you see happening today. For example, there are pharmaceutical industries. In the case of LSD, it's Sandoz that basically developed it and was trying to find an indication for LSD. So it approached and networked with a lot of psychiatrists just to indicate, no, try it with whatever indication there is. And another aspect that was important is that many of those psychiatrists were scientists, practitioners, but mostly practitioners, and they didn't have any records of what they were doing, right? Randomized controlled trials didn't even exist at the time. And it's really a shame that somebody like 𝗃𝗿𝗺, who treated more than hundreds of people, basically, left no record whatsoever. So there's no way that we can even evaluate his success of treating patients. We only know that he did. So that's really something that we should learn from. And the third, I think, a crucial aspect was that when the discussion came up in the 60s, in parallel to the recreational use of psychedelics in general, the hippie movement, it was really the societal debate that ended the use of psychedelics in clinical practice. And that's important to realize, because also now these days we have like a societal debate that's pretty big, and that's also kind of influencing our scientific perspective on psychedelics. So I think these two perspectives always will intertwine, and we have to be careful about them. So then what happened after scheduling? Well, basically only 𝗃𝗿𝗺 continued with the treatment of patients with LSD. He got a special permit from the ministry to do so. And he did it actually up and far into the 80s, like 85, when and then there was a dramatic event, basically. He treated a patient with ibogaine, and that patient died. And that was the end of the story. And he was forced to retire. And after that, there really was no following in a psychiatric community to continue the treatment of LSD. And because there was increased skepticism, primarily also about the use of psychotherapy and psychoanalysis in psychiatry. And we were moving into a different era, which we call the decade of the brain in the 90s. And this is really, for me, this is the start of the biological psychiatry movement as we know it today. And that's also when the pharmaceutical industry made its, required its place on the platform, because they were developing all of these drugs that we now know very well. Because in the 60s, there weren't too many compounds to choose from. But in the 70s, 80s, all of these antidepressants that we now know and the antipsychotic hypnotics, there are tens and tens of them, they were all developed in these decades, in the decade of the brain, and applied in psychiatry by the biological psychiatry movement. And this is also the area where the distinction between drugs of use and drugs of abuse came very, very prominent. Of course, we had the war on drugs that was initiated in the United States that affected the entire community. So and since that time, we have been talking about illicit drugs, illicit drugs, drugs of use, drugs of abuse, therapeutic drugs, or drugs that cause harm. And we note that distinction even up until today, it's changing because of MDMA, because of psychedelics. But that's the history. And that history also is very visible, it has been very visible in the Netherlands. And I want to just show you the example of MDMA. And in the left panel, you see this famous study by the group of 𝗣𝗿𝗥𝗺 showing that if you give a single dose of MDMA to squirrel monkeys, it causes neurotoxicity. So this has basically defined the debate on MDMA for at least a decade. And if you look at the literature in the 90s and the decade thereafter, also in the Netherlands, you find all kinds of publications showing that MDMA users, if you compare their cognitive functions, such as memory or attention, to those who have never used MDMA before, you see that there's a deficit. And there have been prospective studies in Amsterdam showing that if you follow people over time, then the MDMA users do worse on one parameter of memory as compared to those who never used. But in that particular study, for example, it was basically, there was no change in the MDMA group, there was a change in the placebo group. But it was interpreted in such a way that it looked like this is damaging to the MDMA users. So that has been the set for quite a while. And this is also where we in Maastricht actually played, I think, a nice role. Because our approach has always been different. Rather than comparing groups of users versus groups of non-users, where it's always difficult to come to conclusions, because what is explaining the difference? You don't really know, right? It could be anything. We have always opted to go for placebo-controlled trials to have hypothesis-driven research. And we have been lucky that particularly our MDMA research has been funded by the Dutch Research Council on a number of occasions. And here we looked at this hypothesis of neurotoxicity, is it true or not? Or we looked at pro-social effects of MDMA. And some of the highlights, I think, that come from this work is this is a study that Kim and I did in 2004, basically showing that if you give MDMA a single dose to humans, what you find is that, yes, there is an impaired memory during the intoxication phase, but if you ask them to come back to your laboratory the next day, then the memory just goes back to normal. So showing that a single dose of MDMA does not induce pertaining memory impairments. So that was a good finding, I think. We also demonstrated that much of the effects of MDMA can actually be blocked by blocking the 5-HT2 receptor. So we have provided mechanistic information on where this memory effect actually comes from. We've also done studies showing that not everything about MDMA is harmful, but it can also be beneficial in the sense that it increases empathy, which is a fact and a mechanism that's now being used a lot, also in the context of MAPS clinical trials. And more recently, we have demonstrated that MDMA as such does not induce false memory. So it makes users or patients not more prone to suggestions that come from a person, a therapist or anybody else. And I think that's also good news in the clinical context. So we've had a lot of experience with MDMA and controlled studies in the lab, but when the psychedelic movement came along, we've also developed an interest in field studies, because in the field is really where it has been happening for quite a while. And I think it's also fair to say that we as scientists were inspired by what was happening in the field. So we tried to learn from the field by actually visiting the ceremonies and collaborate with the facilitators and allowing them, us, to actually conduct research, observational research, making measures before people either took psilocybin, drank ayahuasca, or had a 5-MeO-DMT smoke, and then measure their mental capacities afterwards. And while doing so, we've seen interesting findings. So people who were administered 5-MeO-DMT, basically what you see is that their mental health parameters, such as the symptoms of depression, decreased over time. And if you look at clinical populations in observational settings, so this is a study from 𝗝𝗿𝗥𝗺𝗲𝗄, you can actually also see that people who are actually depressed, fully depressed, clinically depressed, who drink ayahuasca, and you follow them over time for 3 months and even a year, you see that there's a strong reduction on average. Not for each and every person, but on average, there's a very nice decrease. But then again, if you're working with observational studies, there is no placebo control, and you always have to remember that. There is always a chance that there's a placebo effect that somehow plays a role in this equation. That's not necessarily a bad thing, but you have to be aware of it. And that's something that we actually also demonstrated in what I think is the only placebo-controlled observational study to date. But then our prime activity really is psychedelic research or control studies in our laboratory. And we have done a couple of studies already with psychedelics, and I'm sure you will hear a lot about them. I just want to pick out a few of the highlights, I think. One of them is that we demonstrated that a low dose of LSD, so 20 micrograms, has an analgesic effect, which is quite interesting, because that would mean that maybe you can use it in therapy without actually inducing the hallucinations, while still having an analgesic effect. We're also the first group that conducted controlled studies with 5-MeO-DMT. Johannes will talk about it later. So we did safety studies, and we were also the first to actually measure its efficacy in treatment-resistant depression. Here's a study from Natasha showing how glutamate, or changes, regional changes in glutamate after taking psilocybin, actually regulates the positive and the negative aspects of a psychedelic experience. And more recently, we also conducted a study in members of the Santidaime community, showing that people, even though they are at different times, an individual, of course, in the MRI scanner, that their brains kind of synchronize when they drink ayahuasca, and because they probably use like the same strategies to sort of experience the ayahuasca treatment. So that was quite interesting to see as well. And then something, and finally, some research that we are working on today, and what we are anticipating in the future is basically expanding on the imaging research that we're doing today and trying to make a link, a connection with the human metabolome. And the metabolome you can actually measure in blood, and it gives you access to all parameters and all building blocks of all neurotransmitters in the brain, or all the hormones that you're interested in. And we are really interested to see if we can connect those to changes, psychedelic-induced changes in brain activity that we are observing. And the end goal really is to be able to fingerprint the characteristics of different psychedelics relative to classical drugs of use, and also to be able to predict, based on a blood profile, what the effect of a compound might be on brain activity. And that's something that we're working on in the longer run, but we are collecting data to make this comparison possible. So we are collecting metabolomics data and imaging data for the phenethylamine, so MDMA, 2CB. 2CB is currently running, MDMA has been collected. Tryptamines, so we have the DMT data, ayahuasca data, psilocybin data we also already have. And the third group that we are interested in are the cannabinoids, so these are not necessarily psychedelics, of course, but as contrast, they are certainly of interest. So there we want to compare 𝗣𝗿𝗄𝗆, which is a synthetic cannabinoid, to cannabis. And some of the data that we were already looking at here, so this is metabolomic data that we collected in an ayahuasca study in these santidaime users. And here you're looking at a matrix that tries to connect all the biological parameters that you can measure from blood to the psychedelic dimensions of the 5-desk altered states of consciousness and demographic information on those. It's difficult to read, but if you look at those circles, what they tell you is basically that the serotonergic biomarkers that you can measure in blood, that they correlate much with some of the key dimensions of the psychedelic states, oceanic boundless, and so on. We also found that there's a strong connection actually between the dose that people take of ayahuasca and the endocannabinoid system. So that's also a first. So somehow it plays a role, maybe just peripherally. We don't know whether it actually has a central role, but it's a very nice demonstration. And then there's a circle that highlights the blue part in that matrix, and that basically shows that neurotransmitters like dopamine and noradrenaline are negatively correlated with the psychedelic experience. So it's basically indicating that the balance between serotonergic and dopaminergic neurotransmitters is changed under ayahuasca. And that is also expressed in that graphics that you see on the left. It's basically showing the same thing. So there's a lot of research ongoing, and I just highlighting here a little bit, and I'm sure you will hear a lot more from Kim and all the others today. And I think that's also important to just mention that. This is an endeavor of a research group, and we are not just 3 or 4 people, but really quite a lot of people, which are all here depicted. And actually, I could have added a second page, probably I should have added a second page, of maybe also of students that are working on our projects in the laboratory, but also international collaborations that we have developed over the years. And we could easily fill a page with that. And I think it's actually quite important also to realize that much of the work that we are doing, the quality of that work actually increases by collaborating with other labs who have their own expertises. And that's a perfect way to move the boundaries and the horizon and set goals and challenges. Then with that, I thank you very much.